So failed fixation, we all know, is either because of the badly done surgery, unsatisfactory fracture reduction. We have been told the fracture has to be reduced well. Poor selection of implant in trauma also, like we have already been told what is the best implant to use for the long stem. In the trauma also, if you have used the wrong implant, you can end up in this infection, non-union, AVN. But the primary fractures itself, where it is having osteoporosis, comminution, unstable fracture with loss of posteromedial contact, very important point, and combination in lateral wall. In these cases, your internal fixation is likely to fail. In some of these cases, primarily we do the long stem revision as a primary case, but here we are not touching on to that. But these are the cases which are likely to fail. In young patients, of course, we try to do reosteosynthesis, but in elderly people, to mobilize them fast, we try to think of doing a conversion arthroplasty. So bone quality, the fracture ambulatory, pre-fracture ambulatory level, and comorbidities, they determine the outcome. As we have been told, you should rule out the infection because this is a previously operated case, and keep all the instruments available to remove the implant, like we have already seen in the acetabular revision removal implants or the femoral stem removal implants. They have been showing us what needs. We need something more than this, because a case is like that, you need to remove all the screws and go further. Another case like this, which is a broken thing, and you should have everything ready. The choice of implant, as already been told by Dr. Vijay, uncemented, distal locking, tapered, fluted titanium. This is going to be workhorse for everything. They have also shown Papyrus 2 and 3. This is the stem which we usually use. He has already mentioned about that not to use this COCR stem, which has been by and large. Some cases we may use a long stem cemented in some selected cases. Now, most important thing is exposure, because this is previously operated case, deformity correction in malunion, adjustment of the length, rotation and anteversion. You have to rely sometimes on your tibial foot plane and decide on that. And reconstruction of the proximal femur. This is the most important point, the abductor mechanism, which is the important point we should keep in mind. Primary fracture, which I have already shown, comminuted. Dr. Vijay has already suggested about two approach. The coxofemoral bypass, you go directly through the fracture, which is not advisable because you disturb the abductor mechanism. And the approach which Dr. Vijay has already shown, which is also known as ITLWO, which is where this is the first coxofemoral bypass. Dr. Lard was telling us about this. You just cut the abductor mechanism, go through the fracture site and approach and put the stem. In this technique, Dr. Vijay has already shown, this is the most important thing, is that you preserve the abductor mechanism, keep it laterally, and then irrespective of the fracture plane, you do the osteotomy and put the stem, and again displace the osteotomy, access the hip joint and complete the replacement. So this is another technique in a primary case you have to keep in mind. Of course, abductor mechanism repair is the most important point. We have already seen the Wagner and monomode. Dr. Vijay has already said that they have not reported a single case of the subsidence in a monomode stem, and that is because of the unique marking system which they have. Like here in the Wagner stem, when you mark it, you don't know where your shoulder is going to come. But in monomode, the reamers, they have given two markings. So one is bone reference marking and one is SHL. This gives you an idea where is your shoulder going to be and what is the length of this. So because of this, you have a fair idea that where you are going to rest your stem, and that is the reason why it is not getting subsidence. This is the most important design difference which they have made into that. The most important point, as I said, is the GT non-union, and you might have to use the high-speed burr, excise the fibrosis, but whatever you do, a counterplate, different type of plates or TBW or Clopate, but make sure that your GT is properly fixed, because that only improves the results. These are the cases which we have been showing that with the long stem, the abductor mechanism has been properly fixed with whatever technique you want, either tension band wire or a different type of plates. Sometimes you might have to use a CT scan also to find out where the fracture fragments are, which will help you. Another case here you can see where the GT has been properly fixed in a long stem case. THR or bipolar depends on the acetabular damage, patient's requirement, physical fitness and demand. Based on that, you can decide. But the most important thing is the anatomy of the proximal femur is distorted, and you have to be very careful because the bone quality is compromised. Sometimes the reaming is very difficult, especially when these nailing are used. The neocortices are difficult, and you might have to ream it properly to get the entry into that. As we know, the broken implants are there, and you have to do like this. Couple of cases here, like we all know this, we have already gone through this type of cases in our daily practice. It has failed, and this you have to use a long stem. Make sure the length of the distal stem has to be away from the last groove or the fracture part. Another case where this has failed above and below both places, this was a malignant skate, and then this has been used because it's been supplemented along with the fixation. Another case like this where distal loading stem with additional fixation has been used, you have to keep in mind in certain cases you might have to supplement with this type of plates or a tension beam wire or counter plates. So long revision stem, the modular monoblock is the main important stem. In conclusion, we should consider this as a major revision surgery, keep all the instruments available to remove the implants, rule out the infection. Trochanteric non-union has to be properly fixed with whatever means you need. Bipolar option is a better choice in elderly people, in a morbid people, and acetabular erosions, you might have to do the THR. Thank you.